And it's really great to be here. First of all, it's great to sort of be here with all of you and to sort of take you through a topic that we think is very important. It's also nice to sort of get out of talking to fellow healthcare professionals, trainees, because really at the end of the day, we're all working together. We are a team, and we try to figure out what we can do and what are the best steps to hopefully prevent, serious problems. In this case, we're going to be talking about heart attacks and strokes, which I'm sure all of you would believe are very serious problems. And I'm going to talk about aspirin. I'm not going to talk about other ways to lower the risk of heart attack and stroke, but there are many other ways, and I'm sure Dr. Goodman has stressed those to you over the past several years or so. But we're going to talk a little bit about aspirin tonight. So I titled my talk, Can Aspirin Prevent a First Heart Attack or Stroke, right? It seems like a very straightforward question, and it should have, hopefully, a very straightforward answer, and it does. This is the answer. The answer is yes. So aspirin can prevent a first heart attack or stroke. But I'll probably go on from there, right? But just know the answer is yes. But I would probably argue that that's probably a little bit more complicated, right? It's never that simple. That's probably not the best question to ask. So let's not ask, can aspirin prevent a first heart attack or stroke? But how about this? Should aspirin be used to prevent a first heart attack or stroke? And I will say that I'm working in a large medical center, working with medical students, trainees, colleagues, in all different areas. I think if you asked people, should aspirin be used, it's not simple. And it's definitely not a straightforward answer for everyone. And I will explain to you why. So this is a picture of a beautiful tree. But if you knew a little bit about, ecology and trees, you would know that this is the willow. And the willow tree is famous because it is actually the active ingredient of aspirin. So people have been using the willow tree and the active salicylic acid in it that has been used in the ingredients of aspirin for a very long period of time, not years, not even decades, not even centuries, but millennium. And I will show you some of that now. But this is what you all see when you think about aspirin, right? A typical white pill that says the word aspirin on it. And I'm going to sort of take you a little bit through the history of the story of aspirin, because it truly is a fascinating story. So if you go back thousands of years, actually the Egyptians used bark of the willow tree as a remedy for aches and pains. If you move forward now to only 2,500 years ago, Hippocrates, or the Greek physician, talked about using the leaves and the bark of the willow tree to help with pains and fevers. One of the most famous medical historians or reporters is Galen. He spoke about some of the antipyretic and anti-inflammatory effects of the willow. And then thousands of years later, Edward Stone wrote about how the willow bark helped him, as well as some of his patients, with just these sort of vague maladies, a little bit of fatigue. And then it was only in the late 1800s, right, so the late 19th century, that is when a chemist working at Bayer in Germany really identified what the active ingredient was. And then in the late 1800s, that is when Bayer actually started promoting the drug. So it's been around as a drug that people can take for more than a century. And in fact, I'm going to show you something that I think is really cool. This was an advertisement that existed in the early 1900s from Bayer, which basically spoke about the benefits of aspirin. And if you look in the bottom left corner, they have, bottom right, excuse me, they have in that box disease states that it was used for. It included pain, headaches, neuritis, toothaches, rheumatism. That we all know, right? But look what's in the center in bold, in the bottom, right here. See that? Does not affect the heart. Right? Pretty amazing, right? That's bold. That's like big. Don't worry. You can take it because it's not going to affect the heart, right? Okay. So things changed. In the mid-1900s, there was a physician in California, Dr. Lawrence Craven, who basically started to recommend it for some of his patients, not based on, clinical trials, but just based on this assumption. And then 30 years later, this gentleman here, John Vane, was awarded the Nobel Prize because he discovered how aspirin worked. It inhibited prostaglandin release, which eventually was found to prevent blood from aggregating or sticking together. And in fact, this is sort of a simplified version of how aspirin works. So your cells in your body have these things called phospholipids in their membrane on the outer portion of a cell. They release something called arachidonic acid, which eventually gets released through something called COX-1. That's the enzyme that makes it work. And then you get a release of a lot of prostaglandins. And as you notice, the one that we talk about most is something called thromboxane, which causes platelets to stick together. And it causes the vascular system to get very, very close. So when you use aspirin, you basically knock out COX-1. And that's how aspirin works. So when you take aspirin, you actually get less platelet sticking together, and you get less of these harmful effects. Now, what I think is really interesting, and it took a really long time to figure this out, is that there is another element that gets inhibited, and that's called prostacyclin. And prostacyclin is actually has the exact opposite effect of thromboxane. And the reason why this is so important is because the more aspirin you take, you not only inhibit thromboxane, but you inhibit prostacyclin, which actually has the exact opposite effect. The reason why this is so important is because this is exactly why taking too much of a good thing is harmful. So when you take too much aspirin, you're not only blocking thromboxane, but you're also blocking the good stuff. This is why you have to be very careful when you take aspirin. A little bit is good, a lot is not. So what do we know about aspirin? Okay, so this was data we published a long time ago, 10 years ago, showing that in patients with established cardiovascular disease, right, people who have had heart attacks, who have known blockages, who have had a prior stroke, aspirin is really, really good. Okay, it prevents cardiovascular events, it prevents heart attacks, it prevents strokes, it even prevents all-cause death, right? So aspirin is a really good drug in people that have established cardiovascular disease. When you compare aspirin to some of the other commonly used drugs, drugs like statins or drugs like ACE inhibitors, in this setting, among patients with established heart disease or stroke, it compares very well, right? So on the y-axis, which is on the right here, this is the number needed to treat, right? So you need to treat between 75 and 90 patients to prevent a single death, and it's very comparable for the three drugs. To prevent the cardiovascular event, you only need to treat around 30 to 40. Heart attack, 60 to 90 or so, but it's very comparable, right? Which means aspirin is a really good drug in those patients with established cardiovascular disease. But that's not what we're talking about today, okay? That's a given. That's a gimme, right? That's easy. What about when you want to prevent the first heart attack or stroke, right? So you would think, I would think, sure, why not, right? Meaning it works. We know that it works to block platelet function. So how about aspirin for the primary prevention of a first heart attack or stroke? So I guess the question is simple. Should it be used? So the FDA came out. The FDA came out several times, the last time being 2.5 years ago, saying maybe not. Aspirin is not safe for everyone. FDA says no, others say yes. Do not take aspirin if you haven't had a heart attack, says the FDA. Now, first, let me just tell you the problem with the media and with sometimes reading it is that they tend to simplify things. So let me just suggest, whether it's for this specific question or for other questions, don't believe everything you read. I'm not saying it's not correct, but there are nuances. And I would really urge you that whatever we talk about tonight, whatever you hear in any lecture, I believe very much in the precision of medicine, right? Individualized medicine. So what I say tonight is not necessarily for you. This is for populations. And I would urge you all to talk to your healthcare professional about what you specifically should do. Nonetheless, the FDA says to the broad population out there, maybe not, right? But that seems a little counterintuitive to what I showed you earlier. So, very importantly, the FDA, now 2 times, does not approve aspirin for primary prevention. Now, when I give this talk to the medical students and the cardiology fellows, I go through every trial. I'm not going to do that because it's a little boring, right? It's also, we want to leave at some point. But I'm going to give you the take-home point, right? This is the take-home point right here. 1 slide instead of 40. This was an analysis of 10 trials, more than 100,000 patients randomized. And you see that when you give aspirin for primary prevention, it works. There's a 10% lower risk of a first cardiovascular event. So you need to treat 250 patients to prevent a single cardiovascular event. But there's a very significant increased risk in major bleeding, right? So it's clotting versus bleeding. And the number needed to harm, that NNH, is very similar. So this is literally, if there's one sort of bullet, this is it. For every 1,000 patients we treat for the prevention of a first heart attack or stroke, you prevent 3 clotting events or 3 ischemic events, and you cause 3 bleeding events. That's why it's complicated, right? It's because it's benefit versus risk. So people have tried to simplify this, okay? This was a review article by an Italian researcher who is very, very well known in the area of platelets and antiplatelet therapy. His name is Carlo Petrono. And he tried to simplify it with the following. I'm going to move. Hello? Yeah. So if you look on the x-axis right here, right? This is the risk of an individual person. So this side, their risk is very low. As their risk increases, they move to that side of the figure. The blank circles are the vascular events you can avoid, okay? The red squares are the bleeding events that you cause. And what you see is that as your risk increases, you basically prevent more vascular events, right? So the higher risk you are, you're preventing more and more vascular events, and that's this curve. But the higher risk you are, your bleeding risk doesn't really change much. So literally, because of this figure, and because of the data that contributed to it, almost every guideline will say you should be on aspirin if your benefit outweighs your risk. So how do you determine if your benefit outweighs your risk, right? First of all, that's why you see your healthcare professional to figure out what your individual risk is. But every guideline will say if your risk is above a certain threshold, you should be on aspirin. And that is sort of finding out what that exact point is where your benefit outweighs your risk is really the key to figuring out who should or should not be on aspirin. Anybody have questions about this? Because I just want to make sure you all got it. Okay. You can ask later too. So, basically back to the question, right? Should aspirin be used to prevent a first heart attack or stroke? So this is where it gets really cool, in my opinion, right? So you get this, right? Thrombosis or clotting on one side, bleeding on the other side, right? You want to prevent heart attack, strokes, blood clots, but you don't want to cause bleeding, transfusion, or gastric ulcer, right? That makes sense. Now, what's really amazing is this. So in 2012, a journal called Science, right, which is really one of the most prestigious journals we have, had this editorial and say, will an aspirin a day keep cancer away? Right? So I showed you clotting versus bleeding. Where does cancer come into play? So, well, they've actually looked at this, right? So we've done all these trials of aspirin for the prevention of a first cardiovascular event or stroke. But when you look at those patients and you look to see who did or did not get cancer, you see that if the aspirin group is in the blue line and the control group is in the red line, you see that people who were on aspirin actually had a prevention of development. So this is incidence, so a new onset of cancer by around 12% relative risk reduction, right? So small, it's not a dramatic result, but it definitely suggests that aspirin is effective. And when you look at trials where people were on it for at least 5 years, you see an even more robust and even more striking 20% reduction in the risk of a first onset of cancer. And when you look at a different endpoint, so not new cancer, but cancer death, this shows that if you're on aspirin, you're associated with the 15% reduction in cancer death, but you really only get it once you're on aspirin for more than 5 years. And then it becomes this whopping 35% lowering in the risk, okay? So we've seen this slide before, right? Clotting on the left, bleeding on the right, but maybe it's clotting and cancer versus bleeding. And that would potentially change the equation as to whether or not somebody should be on aspirin or not. So this sort of gets in line with this idea of, okay, maybe aspirin should be used. Now, let me be very clear about something, okay? Because you're probably wondering, wow, it seems great, right? The issue is, and I tried to explain this to you before, is that it's about benefit versus risk, right? So even though there's a relative risk reduction, which means your risk is 10% lower, well, people that are at low risk, right? That relative 10% is very, very little. So let me explain it this way. Let's say somebody has a 20% risk of having a heart attack in the next year. So you go on a drug like aspirin and you get 10%, right? So it goes from 20% to 18%, right? That's a 2% absolute benefit. That's pretty impressive. You would, to figure out your number needed to treat, it would be 50, okay? You would need to treat 50 patients to prevent a single event. Now, let's say your risk is not 20% in the next year. Let's say your risk is 1% in the next year. So 1% goes down to 0.9%, right? So you now all of a sudden, instead of having this giant 2% absolute benefit, you only have a 0.1% absolute benefit. Well, that's not a lot. And then the risk of bleeding outweighs that. So that's why you have to figure out what your risk is. Okay, that's the essence of figuring out who should be on aspirin or not for the prevention of a first cardiovascular event. Now, I wish I could stop here, but it gets much more complicated. Aspirin dose, okay? So remember I started telling you that aspirin works by inhibiting prostaglandins, and then there's thromboxane and prostacyclin. Well, if you use a very low dose of aspirin, right, between 75 and 150 milligrams, you actually had the greatest reduction. And then when you start using higher doses, you actually get a lesser reduction. So this is another great example of more is not better. So let me be clear. more aspirin is not better than less aspirin, okay? That's why when we recommend aspirin, almost always we recommend a baby aspirin. Now, I don't know why it's called a baby aspirin. It is not intended for babies at that dose, right? It is 1/4 of a full tab, right? So it's 81 milligrams, and most aspirins, when you see them over the counter, that's actually the dose that they come in now, 81 milligrams. But just know it doesn't mean that it's something for babies. It's not. But then this analysis came out, okay? This is a summary of an extraordinarily complex article. But it made the following, I would say, hypothesis. I'm going to take this again. So they looked at, I want to get rid of that box. Okay. They looked at cardiovascular events, and they divided all the trials into two groups. Those that were on low doses of aspirin and those that were on high doses of aspirin, okay? What they found in this compilation of studies was that if you were on low doses of aspirin, those people that were at the lowest body weight, right, so 50 to 60 to 70 kilos, had the greatest benefit. And once you were a little bit overweight, your benefit from the low dose of aspirin was not as impressive, right? So this would suggest that low doses of aspirin are best for people at the lowest body weights. Now, if you look at the other side, those are the trials that looked at higher doses of aspirin. Now, higher, we mean like 300 milligrams, 325 milligrams, so a full tab. And in this study, it suggested at least that the people who were at the highest body weight tended to have the greatest benefit. So this came out this year. I can't begin to tell you, and Dr. Goodman is very, very well aware of this, how many people were concerned. Am I on the right dose of aspirin? Should I be taking a high dose? Should I be taking a low dose? So I personally think that this is really interesting. I call this hypothesis generating. This was not designed to test this question. And there have been many, many studies that are done that have not sort of replicated this, including some of the newer studies. But I think it makes conceptual sense, right? That should we be treating a 400-pound person the same way as we treat a 100-pound person? Probably not, right? I mean, it makes sense. Yet we try, and I think drug companies like to market things very simplistically, right? Just because it's easier for everyone to use. So it makes sense, but I'm a little bit hesitant to change everything based on this because higher doses of aspirin have some harm, and that's bleeding. And so, to be honest, I still use the lower dose. In some patients that are very overweight, I consider it, but I measure their platelet function. So that's what I do. But I think it's still an area of significant controversy. But I don't think that this changes practice for everyone. I don't. And the guidelines will not reflect that either. So I think that right now this is very interesting, and we call this hypothesis generating. It's the first study to show this, but I think we need more data to prove this. Okay, so if you go look at the guidelines actually do not make a recommendation in the elderly. And let me tell you what the guidelines in this case call the elderly, and then I'll tell you what I call elderly. So they're talking about individuals 70 years or greater. I call elderly people that are older than my father, so you have to be over 92, because I consider him middle age. My patients love me because of that. But in general, the guidelines really are silent about people that are over 70. And they don't recommend aspirin one way or the other. And I think that made it very, very complicated. But then a trial came out this year. This was published a few months ago. This was called the ASPREE trial. Now, in cardiology, by the way, one of the things we do is we like a lot of acronyms. And we name every trial by a different acronym, and it's really funny when you talk to the trainees and you bring up trial names because they're just like, please slow down, like just let's get through one or the other. But just know that it's called the ASPREE trial, and it looked at community-dwelling adults, right? So these are patients who did not have a particular risk factor. They had to be 70 years or older, or if they were in the United States, they could be greater than 65 if they were Black or Hispanic. And the reason why that was done is because they were trying to identify higher risk individuals, okay, people that had more events. The trial randomized close to 20,000 individuals, but very importantly, 87% were Australian, 13% were in the US, and the median follow-up was around 5 years, just under 5 years, okay? And if you'll note, their composite endpoint, which was cardiovascular disease, showed a non-significant 5% reduction in the risk. And then when you look at their endpoint that was similar across all trials, it's actually the bottom line. It's fatal or non-fatal. It is the second line. The major adverse cardiovascular events, it was associated with an 11% lower risk of heart attack, stroke, or death. Now, this 11%, remember I showed you a long time ago that large analysis of hundreds of thousands of patients? It showed a 10% lower risk. So I think this data is entirely consistent with everything what we've seen to date, that aspirin is associated with a small relative risk reduction, but there is a significant increased risk of bleeding. Now, I'm not going to show you the bleeding data. I'm not going to show you the mortality data. I'm not going to show you that there was some wonky results based on whether or not you were from Australia or the US. It actually appeared to benefit more. There was a significant interaction if you were from the US. I will just say I think this is very consistent with all the data that we have to date. That there is a small benefit from aspirin, but it has to be weighted against the risk of bleeding. Now, I'm going to end just with a few slides that I think are going to, let's say, transform how we deal with this. So I really, really like this slide, but I'm extraordinarily biased because I made it up. So statins, right? We all know that when you're thinking about statins, they are tremendous drugs at lowering cholesterol, but more importantly, at preventing heart attack and stroke. How do we figure out who should be on a statin in general? We measure cholesterol, right? That makes sense, right? We measure cholesterol because the drug works by inhibiting cholesterol. Blood pressure lowering. Very, very, very clearly, when you lower your blood pressure, you have fewer heart attack, stroke, or death, right? No question about it. What do we do to figure out who should be on a blood pressure lowering medicine? We measure their blood pressure, right? Meaning all this seems very simplistic and very obvious, right? Yet, aspirin, it works, but what do we measure to think about who should be on aspirin? I don't know. Does anyone measure anything? No. And to me, this is the biggest tragedy of the field, right? Is that if you think about it, the drug works by inhibiting platelet function. So why don't we measure platelet function, right? Seems obvious, right? Right? So this was the question that I had 10 years ago. And I was like, so then I thought a very simple question would be, great, how do you measure platelet function? Nobody really knows. So we can measure platelet count, right? Everybody has had their platelet count measured, but we don't really know how to measure platelet function. So that's what I do. I've spent the last sort of 10 years trying to figure out how to measure platelet function. We have grants from the government, from the American Heart Association, and we actually have the ability now to measure platelet function. And we're doing all these really cool studies. First, we're showing that when you have high platelet function, you have more heart attack, stroke, and all these clotting events. And then we're showing, I was literally writing this 20 minutes before I came here, when you have very low platelet function, you're bleeding much more regularly. So I believe that this can discriminate between clotting and bleeding really well. And think about it. You would want to use a drug like aspirin in people that have high levels of platelet function, right? If you use it in somebody who has low levels of platelet function, they'll just bleed more. So you wouldn't want to use it in them. So I believe that's how you can discriminate. So to sort of, simplify, right? So when you measure platelet function, and this is what's done by a hematologist, they measure something called platelet aggregation, or how platelets stick together. When you use nothing, in this case, a control, 0 micromoles of epinephrine, nobody's platelets are sticking, right? The more you move over to the right, it means your platelets are sticking more. Well, hematologists do that. They measure how your platelets stick together using a lot of something called an agonist. And they say everybody's platelets stick together, except for that small group in the beginning, and those are the bleeders. So what we do is we measure, right, and these are the bleeders, right, the people who are not aggregating. So what we do is we use very low levels of something that causes platelets to stick together. And the majority of people do not stick, but then there's this small group of people here that I believe are clotters, and we have a lot of data to suggest this. This is not just a hypothesis anymore. But those are the group of people that are much more likely to have a clotting event. So those are the groups of people who you want to see would benefit from aspirin without incurring the risk of aspirin. So this is my last slide, but this is where I believe the field is going, right? I believe no more are we going to be treating everyone the same, right? Whether you're 400 pounds, whether you're 100 pounds, whether your platelet count is 100 or 500, or whether your stickiness is low or high. I think we'll be able to figure out what individuals' platelet function is like, and then figure out whether or not they are at risk for a heart attack or stroke, and then based on that, whether or not a drug like aspirin would be useful for them. And I think that is where the field is going. Now, precision medicine, personalized medicine is being done a lot when treating certain types of cancers. Why don't we do it with aspirin? Why don't we do it with antiplatelet therapy? So I truly believe that is where the future is going. And I think, at NYU, in terms of the Center for the Prevention of Cardiovascular Disease, I think these are the things that Dr. Goodman and myself and others think about on a daily basis, right? So that we don't have to say everyone is the same. So we don't have to treat everyone like they're part of a population, but to treat every individual like the individual that they are. Thank you very much for your attention.
Thank you so much.